Good afternoon, everyone. I am not Sharon Levine. I am pinch hitting for our section chief. I'm Dr. Matt Russell. I am the clinical director of geriatrics here and am so happy to welcome you on this beautifully sunny day that is signaling warmer weather to come, to talk about cancer screenings as we age. We have a phenomenal duo of speakers today, and I can assure you I am going to be listening with rapt attention as well. But first, let me just introduce our moderator, Susan Edgman-Levitan, the director of the Stokel Center for Primary Care Innovations. Thanks, Susan.
Thank you, Dr. Russell, and welcome everybody. I want to add my welcome to Dr. Russell's. So I just want to review a few housekeeping rules before we get started. We mute everybody to eliminate background noise. So don't be frustrated if you can't bring yourself off mute, because we keep the mute on for everybody but the speakers throughout the town hall. You can view the speaker on your full screen, or you can go to the gallery view in the upper right corner of the Zoom screen and click on gallery view, and that way you see the speaker and everyone else who's participating in the town hall. If the picture becomes jumpy or out of sync, click stop video in the lower left corner, and that will often speed up your connection. It's the little icon that looks like a video camera. For questions, and we really hope you have a lot of questions, please put your questions in the chat feature, and the chat is in the middle of the banner across the bottom of your screen. And when you click on that, the chat will come up. And please put your questions in, but I also want to just remind everybody, especially I think for today's topic, that if anything you share in the chat, everybody on the town hall can see. So we really want to discourage you from sharing any really personal medical questions that you wouldn't want everyone to see in the chat. And if you do have an important medical question about this topic or anything, please reach out to your doctor directly. So those are the housekeeping. We are recording this, and it will be on the MGH YouTube site for you to view later, or for you to share with anyone you think might enjoy it. And with that, I am going to go ahead and introduce our speakers today, who are my colleagues and friends. Dr. Karen Sepucha, who is the director of the Health Decision Science Center, which is my neighbor organization in the Division of General Internal Medicine, and also Dr. Leigh Simmons, who is the medical director for the Health Decision Science Center. And Dr. Simmons is also a practicing general internist in our internal medicine practice that is at Mass General on the campus. So with that, I am going to turn this over to Dr. Sepucha.
Great. Thank you so much, Susan. I am going to share a few slides as we start. So get these going.
Yeah. And can you put them in screen? Yeah.
Is that on the right screen?
Perfect.
Okay, great. Okay, so as Susan mentioned, Leigh and I do work here at Mass General Hospital. We do research looking at how people make medical decisions and what are ways we can support patients and physicians to work together to make better decisions. And a lot of times that's about starting new things, whether it's starting a new medication or starting a new screening test. And sometimes it's about stopping things. Do we really still need to do that test? Do we really still need to take this medication, or have we gotten most of the benefit out of it that we need? So today we're going to talk about decisions around continuing or stopping cancer screening tests. So hopefully it's fairly familiar to many of you. You've been doing cancer screening tests maybe regularly for a while now. These are really important tools in our toolkit to help find cancer early. And obviously we're focused on, the screening tests are focused on looking for cancer in people that don't have any symptoms. There's no reason to think you would have cancer. And the tools are really just out there to try to see if we can find something early when it might be easier to treat. And a lot of times people have a discussion around starting the test, but once they start, there's really not much more discussion that happens. And it really is just about when is the time to do the next test, whether that's, every year or every other year for your mammogram, or, whatever the timeline might be for your colonoscopy. There's often minimal discussion. It's just sort of checking a box and making sure that you're up to date on that. Now, like any medical test, any medical treatment, nothing is really perfect. There's always going to be some benefits and harms, pros and cons to these tests, and that might change over time as well. So periodically, we do think it's worth revisiting this decision and taking a little bit of time to think about, well, what are the options? What benefit am I getting from doing this test if I continue to do it? What are maybe the complications or risks of doing this test? And to see whether or not that still makes sense. Does this make sense? Is this meaningful? Is it worth it? And so that's what we're going to talk about today. And this is reflected, even in clinical guidelines that, our clinicians use to guide a lot of care. So this is just an excerpt from the United States Preventative Services Task Force. It's a national organization that reviews and makes recommendations for things like cancer screening. And this is for, colon cancer screening in adults age 76 to 85. That should be an individual decision. And what that means is it's going to really depend on that person's preferences, their goals. It's going to depend on their overall health. And it's going to depend on their prior screening history. In particular, were there any concerning findings? What's their risk for that cancer developing potentially in the future? And those are the things that you want to be thinking about and balancing to determine whether or not this is going to make sense. So there's not a one-size-fits-all decision here. We can't say if you reach a certain age, this is what you should be doing. The idea of this individual decision means it's going to be tailored to your situation, your circumstances, your goals. Now, when we think about decision making, and we talk to people all the time as part of our research about how did you make that decision and how do you approach this with your patients? And so sometimes we hear things like this, I just don't have time to get into a big discussion. My patients would rather that I just make a recommendation. And sometimes we'll hear from patients, what, if my doctor tells me to have this test, I'm going to do it. I don't want to disappoint them. And, these are certainly common approaches to decision making. But one of the things that we're trying to do is really shift the perspective from this being something that is just a recommendation, or I'm just going to do what they say and not ask some questions, not gather some information. Because really what we want to do with our approach to shared decision making is have this be more of an interaction, have this be more of a conversation. And these are the kinds of experiences that we want patients to feel like they've had. Someone listened to me, someone explained the options and the pros and cons, and I really feel like I'm doing this for the right reasons and for good reasons. And so we would want people to be able to feel like they can say that they had this sort of a shared interaction when they're making decisions, particularly for decisions like the one we're talking about today about whether to continue or stop cancer screening tests. So sometimes when we ask people, what's important to you? What are your preferences? What are your goals? It can help to really reflect on some of these issues. Well, how worried are you about cancer? And you might feel differently about breast cancer, colon cancer, lung cancer. You don't have to feel the same about all of these tests. But thinking about and reflecting on how worried are you about developing this cancer? How important is it to you to try to find this early? And then taking a step back to think through, well, if I think about my health or my health priorities, like what is most important to me right now and maybe in the next 5 years? And how does cancer screening maybe fit into that? How does it help me advance my health priorities, or is it more of a distraction? And I really would like to be focusing somewhere else. And so thinking about how this might fit in. And the other thing for some people to just start to reflect on is, how would you feel if your doctor told you that you might be able to stop screening? Does that feel good, or does that make you a little bit anxious? Because people do have different reactions when they reflect on what these questions mean to them. And so as part of our work, we often are talking to patients about their decision-making, hearing from them how they feel about things. And we do hear very different views. So when we asked patients about colon cancer screening, these are all patients who had been having regular colonoscopies, but were due for another colonoscopy. And they were all over that age of, in that age range of 76 to 85, as we saw on that earlier slide, where they're an individual decision. And here's the kinds of things that we heard. Well, some kind of screening is necessary. Why would you give up something that might help you? But we also heard people saying, I'd be relieved if I didn't have to have a colonoscopy anymore. You know, I do it for the medical benefits, but it's not something I really enjoy. We also heard people reflecting on what's their specific family history. I want to keep going with testing. So maybe they have a certain risk factor or something that's in their family history that would really tip the scales towards continuing screening. And also heard from others, it'd just be wonderful if I didn't have to do this anymore. So it's not that there's one of these is right and another's wrong. There's just going to be a distribution and people are going to feel differently. And what your healthcare team is going to want to know is, how do you feel? Because they might not be able to predict whether you're going to be someone who feels wonderful about this or someone who's going to want to continue testing. So if you're able to sort of share that, share your views, share your opinions, then that's going to be helpful for them to then make sure that they're tailoring the recommendations and that they're guiding you in the right direction. Now, one thing that we think about if we're stopping screening, we worry about, oh gosh, what if we miss something? And one of the things in decision making we worry about is, oh, are you going to regret this decision in the future? So when we're thinking about making a big decision, often will help. One thing that will help is to sort of think through and reflect on how you might feel in the future with different sort of paths. And so if someone's thinking about stopping screening, we might ask them to say, okay, well, let's say we decide to stop screening and in a few years we notice some symptoms, order a test and find that there's actually a cancer there. How do you feel about that? Or how do you think you would feel about that? Because you're still thinking about this in the decision context. Would you be kicking yourself that you didn't do the test earlier? Or would you be relieved that you're only having this treatment now because you really need it? And figuring out where you feel on that sort of distribution can also be helpful as you're thinking about, well, you know what, I really would start kicking myself. So maybe I shouldn't stop. Maybe there's something we can do to keep screening a little bit longer. Or if you feel that you'd be relieved, then great. Maybe we're actually okay. And stopping screening makes a lot of sense. And we'll just deal with something if it comes up. But again, having and being able to share how you feel about this with your clinicians is going to be really helpful in order to make good decisions together. So just to kind of wrap up, I think one of the things we want to make sure that folks understand is actually there are options, and there are often options available, including potentially stopping screening for many of these cancer tests. But it's certainly going to depend on how you feel about that. How do you feel about stopping? Are you worried about it, or is it something that you're maybe looking forward to? How does this fit into your health priorities? What's important to you for your health, and how does this fit in? And then obviously, with all of these decisions, who's there to help you with this? Who's going to support you? How do you get folks on board to help you make this decision, as well as help you carry out any components of it if you need help with that as well? So with that, I'm going to turn it over to Dr. Simmons, and just tell me when you want me to advance the slides.
Okay, thank you. All right. Well, thanks again for having us. As Susan mentioned, I am in primary care internal medicine practice and get the opportunity to talk about these issues with my patients every day, and enjoy talking to a larger audience so that the word can get out that when it comes to cancer screening for older adults, these are usually highly individualized decisions that you don't want to embark on without some discussion with your care team. A few important points that I make sure to emphasize. There's no test for cancer that's perfect. That you always miss something or find something that was better not to have been found. Sometimes that's hard to grasp. Well, how could I have a cancer that would have been better to not know about? But not every cancer is the same. Some are very fast growing and frankly would have never been caught at the right moment to offer a treatment that would be helpful for you. And others are very, very slow growing and essentially harmless. There are some patients of mine for whom we follow a nodule in the lung for a long time until it grows. And then the thoracic surgeon says, you know what, it's time to take it out. That was a cancer that was very slow growing. And it was very helpful that we were monitoring it, but not necessarily something that needs to be addressed at that moment. So they can have different behaviors. It's important to know that every test offered for cancer screening has pros and cons and risks and benefits. And we only do screening tests for a limited number of cancers, not every cancer that we know affects humans. So you and your doctor should talk about what makes the most sense for you. What's a cancer screening plan that fits best with your health status, with your other illnesses that we're thinking about, and your personal risk factors. The other important thing, this is something I can't emphasize enough. Have this discussion once, but then have it again. A great time to talk about it is at your annual wellness visit, where it's the perfect time to talk about what makes sense for you, what's changed, let's say in your family medical history, or any symptoms that you want to discuss, where then we're not talking necessarily about cancer screening, but a cancer diagnosis if you have symptoms that are worrisome. You also may have a change in your priorities. I've had some patients who early on in my taking care of them said, you know, it's most important to me to make sure that I'm finding a cancer at an earliest stage. I would do anything to screen for that cancer. But 10 years down the road, when other illnesses have come to the forefront, the concern about finding an early stage cancer becomes less of a priority, and managing the other illnesses are more important. Next slide. So a few things that your primary care team will want to know. They'll want to know, is there a change in your family history that might warrant you getting more intensive testing? An illness for a sibling, an illness for a child, close cousins. That may be important in your own medical screening plan. What testing have you had done before? Your primary care team is going to review that. Have you done stool blood testing or mammograms? What's your pap smear history? Not everybody's cancer screening history is the same. The results of prior testing will inform future testing, so it's important that that's available for review. Do you smoke or did you smoke to significance? That matters a lot when we think about lung cancer screening. And then some general questions, which may not be a blanket answer for all types of cancer, I just have to say, but how worried are you about finding out about cancers early? How worried are you about other conditions you're dealing with? I hear all the time from my patients, my dearest friend had a certain type of cancer. It's really important to me to make sure I've taken the right steps to find any problems for myself early. I've also heard other stories like my dearest friend had a really tough experience with being treated for a cancer. Just know that that story and my knowledge about her illness really informs how I think about being tested and treated for cancers. So your own experience and experiences of friends and family may inform how you want to approach this. Next slide. So next, I'm going to talk about specific types of cancers for which we have established screening tests. There are some cancers for which we do not have established guidelines for screening everyone, but depending on your personal risk factors, a doctor may recommend a very individualized plan. Some examples there that I won't be going into great detail in these slides on are, for example, ovarian cancer and pancreatic cancer. For people who have very high risk circumstances, there are sometimes individualized screening plans recommended. What I'm going to talk about next, though, are the much more commonly screened for cancers. First, colorectal cancer. So guidelines changed on this, and I mention this because you may have friends or family members who fall into this younger end of the screening spectrum, and you may want to inform them about this. The guidelines changed 2 years ago, 3 years ago now, that we should start screening everyone, offer screening everyone at age 45. colorectal cancer screening continues for at least 30 years from that, up to age 75, and maybe longer, depending on your health conditions. But most people over age 85 should not be screened. That doesn't mean you shouldn't be tested if you had symptoms that are worrisome for colorectal cancer, like a change in your bowel habits, rectal bleeding, or an iron deficiency anemia. It just means that we wouldn't be doing the screening tests for someone without symptoms after age 85. At that point, the risks of the testing outweigh most of the benefits. There are 3 ways currently to be tested, most commonly. There are stool cards that look for blood, and you mail these back usually to your doctor's office or to a hospital lab, and those are done every year. There is the test called the Cologuard, which you've no doubt seen ads on TV for, with the dancing or talking box that arrives on your doorstep. You actually mail a bowel movement in a box to a company called Exact Sciences. They are the only company doing this testing right now, but this is a test for blood and also abnormal DNA in the stool. This abnormal DNA is shed by the tumors or a high-grade polyp in the stool, from the colon into the stool. And this testing, if normal, is done every 3 years. Then there's the option of doing a colonoscopy. Usually that's every 10 years. It might be more frequent if you've had polyps before, or if your family history is worrisome for colorectal cancer, or if you have colorectal cancer in the family, sometimes more frequent intervals are recommended. A few special considerations, as I alluded to, a family history of colorectal cancer or polyps sometimes means testing before that younger age limit. I've written 50 here, it really should say even earlier than 45. Or continued testing at older ages. Sometimes we extend it past if there's a strong family history. Personal history of colon polyps. So if you've had colon polyps, you may be, again, doing testing more frequently, or your doctor might say, for you, the stool cards or Cologuard are not appropriate. We need to keep doing the colonoscopy. It's very important that if you do have polyps found on your colonoscopy, to make sure to tell your siblings and children so they can discuss this with their doctors to see if any enhanced screening is recommended for them. Next slide. Lung cancer screening. This one is a little more complicated to determine who benefits the most from lung cancer screening, but lung cancer screening is an excellent test for finding early stage lung cancer at potentially more treatable stages. So it's important to know what the criteria are. People who are candidates for lung cancer screening need to meet these 4 criteria. You need to be between ages 50 to 80. You need to have smoked 20 pack years, and that needs some explanation. So pack years are calculated in the following way. Let's say you smoked a pack a day for 35 years. You would have a pack year history of 35 pack years. 1 pack a day for 20 years gets you to that 20 pack year quota. Another way it can be calculated is, let's say you said you smoked a half a pack a day, roughly, maybe 10 cigarettes a day for about 40 years. That also gets you to that 20 pack year history. So that's how that's calculated. You must have smoked within the past 15 years. Now that's still part of the United States Preventive Services Task Force guidelines. That criterion has been eliminated from American Cancer Society guidelines. So be aware that some doctors and some insurers may say, that's okay, we can go ahead and do the lung cancer screening, even if you stopped smoking, say 20 or 30 years ago. Okay. But generally we say you either need to still be smoking or have smoked within the last 15 years to qualify for the testing. And this last part is important. You must be healthy enough and want to be treated for lung cancer if found. I know that sounds strange to say, but you could imagine that somebody might be dealing with another very serious illness and might say, I really don't want to know about this. I'm frail. I worry about how I would deal with getting a biopsy or certainly with treatment. So that's important that that's taken into consideration in your conversation with your doctor. One other important thing to know, though, about lung cancer treatments these days is that for some people who have, for example, advanced COPD, who might not do well with removal of a tumor from their lung, are in fact candidates for radiation therapy only to treat the lung cancer. So it's something where it's worth a detailed conversation as you consider how to manage the findings from a lung cancer scan. And here at Mass General, we have something called the Lung Nodule Clinic, where it's a radiologist, a pulmonologist, a radiation oncologist, and a surgeon who all meet together to give advice in more difficult situations on the best treatment or diagnostic and treatment options for patients. This screening test is done with a CT scan of the lungs done once a year. And it's always important to talk about what we call incidental findings, other things that might be found on a scan that would need some follow-up, even though it's not what we were looking for in the beginning. Things like coronary artery disease, plaque in the arteries of the heart, an aortic aneurysm, a swelling of the aorta leading out of the heart, or adrenal nodules, nodes or spots seen on the adrenal glands, all very common and may need some further management. Another piece of lung cancer screening is that if you smoke currently, one of the requirements of getting a scan, for Medicare anyway, is that your doctor documents that you're getting smoking cessation counseling. So that's an important piece of it, that they've documented, they've talked to you about strategies for helping you quit. Next slide. Breast cancer screening. Okay, so breast cancer screening is generally offered to all women aged 50 to 74 and should be offered to women 40 to 49 and in many cases women over age 75, but at those ends of the age spectrum, it needs to be with a careful discussion of both the pros of doing mammography for breast cancer screening and the potential cons. What could be the downsides of doing these tests? The testing for breast cancer includes, for most patients, a clinical breast exam by your doctor or nurse practitioner, and that would be done yearly or periodically determined by your clinical conditions, and a mammogram either every year or every 2 years. Some patients need to have, if they're at particularly high risk of breast cancer, need to have breast MRIs done as part of their screening protocol. That's not as common, and it's not as common as you get older that the breast MRI is recommended. But in cases of a strong family history of breast cancer, and if your mammogram has shown extremely dense breast tissue, sometimes MRIs and sometimes ultrasounds are recommended as a supplemental screen. The decision on how often to have a mammogram done is based on your personal risk factors for breast cancer and the breast density seen. So if the breast density on the mammogram is high, usually a mammogram every year is recommended because the mammogram doesn't perform as well. If the breast density is low, meaning the breasts are almost entirely fatty, the mammogram performs better as a test, and the radiologist can see an early cancer better. So that discussion of how often to do it is up to your doctor and your discussion with them. Next slide. Cervical cancer screening. This is an important topic, and it's one where particularly one's history of cervical cancer screening and pap smear results really weighs into the decision about how long to continue doing the pap smears. Cervical cancer screening is screening for cell changes and cancers at the end of the uterus, at the cervix. This is recommended for women 21 to 65, and some people over age 65 if they've had certain types of cervical changes in their lifetime. This is done by pap smear testing, which is not as frequently done as it used to be. It used to be yearly. Now it's every 3 to 5 years. And a few important considerations for patients. If you do not have a cervix, either removed as part of a surgery for benign disease, a hysterectomy for, say, fibroids, or removed for any other type of gynecologic surgery, no pap smear of the cervix is needed. However, not everyone who's had a hysterectomy had their cervix removed, and it's important that their physician check and see if they still have the cervix. If they do, then they could have cervical changes that lead to cancer, so it's important to have that documented. Another important thing that does not affect older people as much, but it's something to be aware of for the young people in your life, that most young women and men now are being vaccinated in their teens against human papillomavirus. And we may see that the there's going to be a change in how often pap smears are done as these cervical changes and cervical disease becomes much more rare. I just heard a report about a public health report from Scotland where they had a very good campaign to get Gardasil, the human papillomavirus vaccine, given to young people. They have not diagnosed a single case of cervical cancer in anyone who got Gardasil as a teenager. And now these people are in their early 30s and they've not diagnosed a single case. It's just one of the countries that had done one of the best campaigns for immunization and tracking. So some very hopeful signs about where we're going with this condition. We do, however, diagnose cervical cancer in older women who have not either have had abnormal pap smears in the past and didn't realize that they might need to continue doing the testing. And had stopped around age 65 mistakenly, or who had never been screened. So it's important that those continue. Also, if you are someone who's immune suppressed because of HIV disease, is the usual any type of T cell immunity deficiency, those patients may need to continue screening longer, and that's an important thing to make sure gets discussed with your doctor. Next slide. Prostate cancer screening is something that we at the Health Decision Sciences Center are well familiar with because this was really one of the original case studies for shared decision making. In the early 80s, a blood test was developed to detect prostate cancer recurrence for men who'd been treated for prostate cancer, called the PSA test. And then there was growing interest in seeing if whether you could find prostate cancer early and ward off problems for people who may not need to, suffer the effects of developing advanced cancer. It became clear, though, in the coming decade and a half, that the use of the PSA blood test was finding a lot of low-grade cancers and leading to treatments for men who actually weren't going to have a problem with prostate cancer in their lifetime. And it wasn't saving as many lives as we'd hoped. And the treatments are not benign. They involve removing the prostate sometimes, radiation therapy that can come with a lot of side effects. And primary care physicians particularly started to develop strategies, conversation scripts, and tools called decision aids to help them have high quality conversations with their patients about whether they wanted to do the PSA test or not. So the current guidelines for PSA testing, and these have gone back and forth over the years, to be clear, are that all men over age 50 should talk about prostate cancer testing with their doctors. PSA blood testing may be recommended for men 55 to 69. Most men over age 69 shouldn't be screened for prostate cancer with PSA blood testing. Now, that doesn't necessarily apply for someone who's been followed for an elevated PSA level or has some risk factors that have made their doctors concerned that they may need to continue that screening. But as a general statement, the greatest benefit of this blood testing for prostate cancer is between ages 55 to 69. How is testing done for for prostate cancer? The first is digital rectal examination of the prostate by the physician. This testing has fairly limited value. It doesn't have zero value. We all in primary care can think of cases where we did diagnose a prostate cancer based on physical exam alone, or where the PSA blood level was actually normal or low, but the patient had an abnormal examination and a prostate cancer was diagnosed. But many doctors have moved away from that as a primary screening method, and it probably shouldn't be done without a routine or schedule of PSA blood testing as well. And then the PSA blood test can be done every 1, 2, or 4 years, depending on the levels. For men who have a very low PSA level on initial screening, they often will be repeating that blood test every 2 to 4 years. If they are at higher risk of prostate cancer, or if the levels were slightly elevated, they will be doing the testing more frequently. I emphasize always that the PSA prostate cancer screening guidelines change every few years, and it's important to stay in regular conversation with your doctor about the best monitoring and screening plan for you. Next slide. Okay. All right. So that wraps up that part of the content talk. We would love to take questions. And Susan, I will turn to you for moderation.
All right, thank you. So we've got some interesting questions that and I'm actually going to read from the chat because I think it'll be easier. If you are someone who would rather have a false positive than miss a true positive, and an ounce of, hang on, sorry, something, and an ounce of prevention worth a pound of cure, will you be able to obtain the test at issue?
I just had this conversation with a patient this morning who we're talking about colorectal cancer screening.
I'm not, they don't say, but keep going.
Yeah, I just had this conversation. So this patient is in his mid-80s, had a colonoscopy about 15 years ago. It was normal. He wanted to continue colorectal cancer screening, but wanted to do it the Cologuard test, the DNA and blood test. He's now past the age that Medicare will pay for it, but he wants to keep doing it and paying out of pocket. And he understood that. And I said, listen, I don't think I can get Medicare to pay for it now. And you have to know that the Cologuard test has a higher false positive rate the older you get because our cells just tend to shed more abnormal DNA. So it can say there's a problem when there actually isn't one. So I think it's worth a careful conversation. Now, it's one thing to say you'll pay for a Cologuard test out of pocket. It's not cheap, but it's not thousands of dollars. It's about $700. It's another thing to say, I want a preventive surgery or removal of organs, or I want to do that colonoscopy, even though I'm at high risk for complications. That warrants a much more careful conversation because when you're going down the road of something that really could cause some harm, it's important to have that discussion. I think it's important that we talk about that. And honestly, that for an individual with a screening test, at a certain age, we hurt more people than we help.
Yeah.
We all know someone who was helped by a test. It's easy to think about. And I, as a doctor, will quickly come to mind, like, thank goodness we went ahead and did that test. What we don't think about so much are the people who had a normal test. So they didn't, I mean, they might have gotten peace of mind, but their health didn't necessarily benefit. Or people who suffered some financial harm or hassle or put that ahead of doing something else important for their health. And those are the things that are harder to talk about because they're kind of silent. But it's worth a conversation. It's worth a discussion. Usually, yes, we can get these things paid for. That's not so much the concern. It's whether we should be doing it. And many doctors will say, as long as my patient understands to the extent we know it, the risks and the benefits, will proceed. It's just not a blanket recommendation I would give to all of my patients her age.
Leigh, one thing that you mentioned, and I think maybe Karen mentioned as well, that I want to make sure that everyone on the call understands is, can you say a little bit about what a Medicare annual wellness visit is and why they're helpful and why everybody should get one? And Matt, you may want to jump in too, but go ahead.
Do you want me to take it, Leigh?
You know what? Maybe so, because you all may do them a little differently than my practice does. So tell us what you all do in senior health.
I think we do. This is where we host a lot of these conversations. This isn't exactly many of us have the idea of this is my annual history and physical, where the doctor takes me from stem to stern and does a physical exam. But we do that already in geriatrics quite frequently. What this visit is really for is to make sure that you are receiving age-appropriate screenings, and through the lens of all the things that Dr. Sepucha and Dr. Simmons said, what is the context of this? What is the actual benefit? I have many patients who might be very anxious that they're going to miss a cancer screening on something that I don't think as their doctor is actually going to be the main concern for them as they're aging. And I think we always want to have that bidirectional conversation, because we don't just want to send someone off for a test because a guideline says it or it doesn't say it, and the patient gets anxious, and then you've ended up testing for anxiety to reassure anxiety, not to actually reduce the person's risk of having the disease and then getting sick from the disease. I'd also like to say that in geriatrics, when we send a patient for something like a colonoscopy, oftentimes we're doing that because we're looking for something. And we need to be very clear that there's a difference between diagnosis-driven colonoscopies and cancer screening colonoscopies. So for us, if I'm sending an 84-year-old for a colonoscopy, it may be because their iron level is low or because they've had some blood in their stool. That's not looking to see just average risk. That's saying there's a problem, we have to diagnose it. But if someone is totally asymptomatic and 85, sending them for a colonoscopy, I don't know if any of you have had the joy of a colonoscopy prep. I have, and I can say that, if I were thinking about as I get older, if I have mobility challenges, if I am by myself, if I have to get up quick to go to the John, these are all things that, while seemingly the goal is I want to screen for cancer, I could actually fall and break my hip. And so setting people up for these tests, you really do want to be thoughtful and make sure that we're doing it appropriate for the context of where that patient's at. That's what I was going to say, Leigh, so feel free to.
I think that sounds great. I remind my patients that the annual wellness visit, it's kind of like an annual good review of the latest that I know about. Guidelines have changed. So that happens every year. There's some new things I want to tell my patients about that are not just cancer screening, immunizations, new blood pressure guidelines, osteoporosis screening, and for them to catch me up on what's gone on in their family history, in their life, what's a priority this year.
And I also think that as part of that visit, and correct me if I'm wrong, but I think that another important part of that visit is making sure that people are getting the nutrition they need, the exercise, that their abilities to do all the things that we need to do every day, like dressing, toileting, whatever, are okay.
I spend more of the annual wellness visit talking about, and it sounds goofy to say it, but one of the queries you get on the health risk assessment form is about legume consumption, nut butters and things. It turns out that is truly one of our best markers of nutritional health as an older adult. Are you eating peanut butter and legumes regularly?
Yeah.
I just talked about peanut butter all morning, actually. But those are also important things to talk about with your doctor. Your nutritional health becomes incredibly important in your 70s, 80s, and 90s.
And Leigh, I can just add a little anecdote about the peanut butter, because I was involved in developing the questionnaires that are used in the annual wellness visit, and asking people about legumes and peanut butter was one of the questions. And early on, we were all kind of like, really? And only to find out that how much protein someone is getting is the one marker in everything that gets reviewed in the annual wellness visit that is actually linked to prediction of mortality. And I think that was news to our doctors, to our patients. That was certainly news to me. But it makes me smile when you say you talk about peanut butter, because it's actually an excellent source of protein for all of us. That's not that expensive. Anyway, let's go to another question. And this again is you all are asking really nuanced questions today. This one is, people who think they would rather not have a test can often change their minds when sadly they turn out to have the illness and it may be too late for the best treatment. This was seen with COVID in unvaccinated people in the early days who were hospitalized and dying and begging for the vaccine. How do you and how do we take that into account?
Great,
I'm
Karen.
going to open this to anybody.
Yeah, I mean, I think that, this is a really important component, and we did mention that in the slides on that regret, so can we anticipate that regret? Because that's certainly something that happens with decisions, especially when the outcome isn't so good. Of course, you can have the vaccine and still have a bad outcome, a potentially bad outcome. So it doesn't prevent necessarily that regret. But I think when you guys are considering and making these decisions, playing through some of these scenarios and saying, what would happen? How would I feel if we were here in 3 years and we noticed something? Because that might also help you then feel more comfortable or confident with whichever path you choose. That said, I mean, I think as someone had mentioned, there's a lot of anxiety for anything, I mean, anything. So we don't want to use screening tests. They don't necessarily treat anxiety. And we want to make sure that there's actually a potential benefit to these tests. I think one thing that folks might not understand is if you have multiple clean tests, you've been screening, you've been doing this all along, your chance of developing a cancer might be very, very small because you've been doing such a great job and there's no indication. So the risk is very, very, very small. So that's another thing to I think factor in is what's the potential benefit, and what kind of peace of mind might you get from the results.
Matt, I'm going to pose this question to you. Can you talk about the benefit for HPV vaccinations in men?
Sure. That's unfortunately for most of us who were around before the vaccine was available, we've already been exposed to it. So we're not offered the vaccine. So that's at least my understanding of it. It's usually now offered in the teenage years.
I'll just add, because my practice does include some of that younger group. There is a benefit in prevention of all types of HPV-related cancers, whether that's cervical, vaginal, anal, and throat cancers. So many head and neck cancers are caused by HPV. And people can get vaccinated up to age 45, men and women. We just don't have good mechanisms for figuring out who wants to be, who has already been exposed. And there's variable insurance coverage of the Gardasil vaccine, but it is available and FDA approved for up to age 45. But 11 and 12-year-olds, girls and boys, are getting the vaccination now. So we'll see this benefit in the subsequent generations for sure. But if people up to age 45, they can get vaccinated against it.
Okay, thank you. And we have another question about how often should you have a skin check? A dermatologist, somebody looking at all of you to make sure that there isn't anything worrisome that many of us can't see.
If you're Irish, every other year after confirmation.
Okay.
I'm sure there's a more official. It
does not sound like the U.S. preventive task
right. No,
force to me.
but it does speak to the fact that, if you have a lighter skin tone that, you always burn and never tan, that is the person who is higher risk for developing skin-related cancers. And so I don't actually know the specific breakdown of, frequency of years, but if folks have had superficial skin cancers removed or burned off, that usually then sets them off with their dermatologist for like an every year or every 2-year screening. Certainly, if you are on the fairer side complexion, it is never a bad idea to be evaluated by a dermatologist for a comprehensive skin exam, because many of us grew up at a time when we didn't know the harms of sun and sunburn, and we did not use sunblock. Many of us have had blistering sunburns. Those things do suggest, hey, I probably should have an evaluation.
Okay, thank you. I don't think we have any other questions, so I'm going to really encourage people, if there's anything that you haven't asked about that's on your mind, please submit it. And actually, Monique, I know we got one question that came in before the session today, and I don't have that right in front of me. Could you maybe share that with our speakers?
Yes, let me go find that. Hold on just one moment. Yeah.
Thank you. Sorry to put you on the spot. I don't want
Susan,
to
there
start.
seems to be one, and I might have missed that you asked this. Is there significant benefit for HPV vaccination for men?
That's what Matt
Yeah.
just answered.
Oh,
Yeah.
okay, sorry.
It just in our
I thought you were doing skin check.
yeah, no, the answer is it will be good for the men, for the people who will be men.
Young men.
For those of us who are already past 45, it sounds like we're out of luck on that one.
Okay, got it. Thanks.
Oh,
There it is.
okay. Did you just put it into the
I
chat?
did. Yes, I did.
Okay. So I'm just going to read this. I'm 77 years old. At my last colonoscopy 11 years ago, some nodules were removed and I was given the all clear. I was told to have another colonoscopy in 5 years, which I neglected to do. I'm wondering if I should have a colonoscopy now, or is it too dangerous at my age? And if it's too dangerous, what options do I have? Leigh?
Yeah. So if faced with a question like this from a patient of mine, there are a few things that we would take into account. First of all, I would say this, as Karen and I found from our work looking at decisions on colorectal cancer screening for people 76 to 85, this person's story is more typical than someone who has never had colorectal cancer screening or has always had normal studies. So it's actually the norm that most people had colonoscopies and had polyp removal. More had polyps than who hadn't. So this idea that maybe I'm not quite on the screening schedule and I've fallen off a bit is pretty normal. So there are a few things that the gastroenterologist and the primary care doctor would want to know about. The first is how many nodules, how many polyps, there probably were polyps, how many polyps were removed? That makes a difference. If there were 8 polyps removed, that's somebody who's a higher risk of developing a colorectal cancer than someone who had 2 very small polyps removed. The size of the polyp and the number is important. The other piece is, this person asks, is it too dangerous? While colonoscopy can have some risk, most people don't call it a dangerous procedure. But in some circumstances, like advanced kidney failure or heart failure, where doing the prep and the anesthetic for the colonoscopy could really put some stress on your body, that might be something that would concern the doctor. So those are the pieces worth discussing. Sometimes people ask about, well, what about using a stool test instead at this age? Also worth discussing. Some gastroenterologists are more open to that than they were in the past. But again, I think it would really depend on what did that last colonoscopy look like? Again, with these large polyps, were there many of them, or were they very small, and you don't have a strong family history or personal history of advanced polyps? All those things are going to go into that consideration. I should have also mentioned the pathology of the polyp is important. There are some polyps that are considered very low risk of progression to colorectal cancer, and some that are considered almost cancerous. So that matters too. So with that information provided, I can tell you the questions to ask next of your physicians.
And Leigh, it sounds to me like this is the kind of thing that it's very much worth having an actual visit
Oh,
to
yeah.
discuss.
Yeah. This
Yeah.
isn't something that somebody could quickly look at your chart and give you the right answer. They would need to ask a bit more, get a little more info about the first colonoscopy or the most recent colonoscopy, and talk with you about what was on your mind.
That's a perfect segue to next month's topic, communicating these kinds of questions to your provider. So Susan, I'll let you take
Yes. So next month, our next town hall will be on March 7th from 1 to 2 p.m. And we're going to be talking about sort of tips about how to use Patient Gateway There are many features on Patient Gateway that we're not sure everyone is aware of or where to find them, and some are quite helpful. We also are going to talk about some guidelines about what are the appropriate things to ask about in a Patient Gateway message versus topics that you really need to schedule an appointment for. We know, just as one example, we now limit the number of characters, words, whatever you can use in a Patient Gateway message. And so one guideline is if you need more than one message to talk about something, it's probably something you need to schedule an appointment to talk about, because it's probably more nuanced, just like the question that Leigh just answered. So we think it'll be a very interesting town hall, very practical. And our speakers, one is our sort of leading epic e-care physician who is the medical director of our Everett Family Health Center. And the other person is the chief clinical person for primary care in our division, Dr. Michelle Leroux, who has also been very involved in work around how to improve the use of in-basket messaging, which is where your messages go when you send somebody a message in Patient Gateway. So I don't know if Karen and Leigh have any closing comments, or Dr. Russell, but we're almost at time.
Susan, just wanted to add to your mention of, yes, I think scheduling an appointment is good. This would also be fine to be a video visit or a phone visit. It's not so much the physical exam, it's the space to look through everything, talk it over, make sure you've come to a good decision. And our gastroenterologists have expressed their desire to have these kind of visits with patients. You don't need to always meet with a gastroenterologist before your colonoscopy, but if you're someone like our patient who asks those good questions, maybe that's a perfect setup to have a good conversation.
Yeah, I think that's really helpful. Thank you. All right. Well, I hope everybody gets out and gets some vitamin D in this sunny day. I don't know how cold it is. I'm kind of chilly, but I hope you have the wonderful rest of your afternoon, and we look forward to seeing you next month. And thank you so much to Dr. Simmons and Dr. Sepucha and Dr. Russell for all of your wonderful information today. Take care.